tratar esse orifício. Deu certo, ótimo, mas poderia não ter cedido também, e se perderia nessa possibilidade, talvez a possibilidade de tamponamento. Sempre se poderia cateterizar a veia central novamente através do catéter mesmo, né? Essa opção passou, foi discutida entre vocês?
Foi discutida. Uma das ideias que surgiu na hora foi que o paciente não tinha coagulopatia, não tinha nenhuma doença hematológica, e ele estava em boas condições, estava hemodinamicamente estável. Então, o raciocínio na hora do Dr. Nelson Volosca foi: se a gente consegue tamponar lesões venosas ou orifícios venosos com a pressão, com a compressão, por que uma lesão de cava
Isso era
não
um cateter
tamponaria
9F,
também?
10F? O que era? Aquilo é um
10F.
10F.
Por que precisou ficar 20 minutos de pressão, depois que botou os pontos?
Não
só foi pressão,
foi só
mais nada.
tamponado.
E não podia botar uns pontos também, para ter certeza?
Podia, mas ele optou por fazer apenas a compressão, baseado nesse raciocínio de que o tamponamento seria suficiente.
Excelente que o caso deu certo, mas minha preocupação é se o doente começar a tossir no pós-operatório, no pós-procedural, que talvez ele comece a sangrar e você não vai saber. Mas ele tinha
Ele tinha um dreno, isso era uma possibilidade que foi contemplada pela equipe, então por isso o paciente ficou monitorizado nesse dia e com o dreno de tórax vigiando, né? Ele ficou num ambiente mais ou menos controlado.
Greg, what do you think? I'll get there. Greg, any comment on the case? Just pressure for 20 minutes, and it fixed the problem.
Well, I think that would probably work, but I have another comment and a couple of questions.
Yes.
I think the best way to treat a complication is never to have it in the first place. And when you placed your guide wire, did you have the guide wire into the inferior vena cava?
Yes.
And was the sheath advanced under fluoroscopic guidance? Because if the guide wire is all the way in the IVC and you advance the sheath under fluoroscopy, it's hard to see how you could end up in the wrong place.
Yes, it was. Thank you very much for your question. It was very interesting to see that the catheter was always on the right side of the heart. We never suspected that it had caused a lesion. The patient was stable, and we really saw it just when we pushed contrast.
What was your question? Any done? Okay, Rich, I don't know if you got the case in the beginning. You didn't have the simultaneous translation. You want to make a comment?
My comment was going to be similar to Enrico's. You had a beautiful picture of that clot in that extra pericardial SVC. I would have been tempted to put a few sutures in it while you were there. Not that I've ever placed sutures through a thoracoscope, but I'm sure thoracoscopic surgeons could do it.
Yes, this was actually the first case that was treated like that. Others have treated with a suture. This was actually a new way of treating, a new experience. But Nelson Volosca has a great experience with the thoracoscopy, so he could have done suture. And we had also a thoracic surgeon nearby just to see what we were doing. So we could have done it, but we chose not to do it.
Frank, what do you think?
I think it was very well done, and the pictures were beautiful, and obviously it worked. I would worry a little bit, Arno, about putting a balloon in the SVC. It's a pretty big structure, and you're cutting off a good bit of the cardiac return, and the patient would, if you had to leave it up for a long time, the patient would get hypotensive. But that's another way of doing it. I think this is the right way to do it. And you did it under control so you could watch it. Yes. You had a chest tube in. I think this was brilliant. And big holes in vessels clot. So and certainly in veins. So I think this is a very good way of doing it. It's like if you tear the vena cava, sometimes you just put pressure on it, wait, pray, and it stops. Whereas if you go after it and try and dissect it out, you end up getting worse bleeding and so forth. So I think this was a very good way of doing it.
Thank you.
Yeah, my only, I don't want to be controversial, but my only point is that if you're there already and you can't place a stitch and Nelson has experience with
Yes.
it, why take a chance? Or that's because we don't have experience. I don't have any experience with it, that's why I'm saying that. But if I'm right there, I would just put a stitch and then I put some pressure.
Yes.
Then it'll start to bleed.
Depends. What do you think? Would it bleed?
I think it's good to do some pressure before the suture because you can make the bleeding, make less bleeding. So if you do pressure, and when we saw the clot, we were so happy. It was stable and it was a well formed clot, and then we chose not to do the suture.
Okay, so it's not bleeding when you open.
It was bleeding when we removed the catheter. It
it
began
bled.
bleed. It bled again, but then we put the
Pressure.
pressure, and we waited
Well, very
to
interesting.
see what would be,
Yeah.
which would be the next step.
Okay, Arno has another question.
Yeah, maybe the most important issue in this case is that you should not remove the catheter until you're ready
Yes, certainly,
to tamponate adequately. I think
absolutely,
this is the more important, no?
absolutely.
That's for sure.
Uh,
There's not much structures around that can tamponade such a hole there, I'm sure.
Yes.
Okay, it was great. Well,
Okay.
great way to start the Pan-American video session. Thank
Thank you very much.
Great.
Thank you. Thank you.
Somebody goes to Nelson.
Oh, thank you.
States and